there is this this very specific, almost universal kind of vulnerability to sitting in a doctor's office.
Oh, absolutely.
Like, you know the exact feeling. You're perched on the edge of that examination table, and, well, the tissue paper gown is crinkling loudly every single time you shift your weight.
Yeah, and the room is inevitably freezing cold.
Freezing.
Yeah.
Always. And you are just, you're just waiting.
And while you're waiting, you're usually rehearsing.
Right. Running through the script in your head.
Exactly. Running through the bullet points, trying to figure out exactly what you want to say. I mean, you're trying to condense months of suffering into this neat little elevator pitch.
Which is, honestly, that's the most agonizing part. Because if you've been living with a complex chronic pain condition, it touches everything.
Everything.
It dictates how you sleep, how you walk down the stairs, how you interact with your kids. And, going into that sterile room, that the absolute second the doorknob turns, the clock starts.
It really does. You have, what, maybe 5 to 8 minutes?
Yeah, 5 to 8 minutes to explain this massive, overwhelming lived experience to someone who, let's be real, already has one eye on their laptop.
Right, which is why people so often leave that room feeling just entirely invisible.
Completely unseen.
Yeah. You pour your heart out, and in return, you get, well, a generic prescription. Or worse, you get that tilt of the head.
Oh, I hate the tilt of the head.
Right. That sympathetic, slightly condescending look accompanied by the subtle suggestion that your pain might just be exacerbated by stress, or in less generous terms, that it's all in your head.
It's incredibly demoralizing. But we've been going through this massive stack of source material for this deep dive, clinical guidelines from the Scottish Intercollegiate Guidelines Network, umbrella reviews of psychiatric data, and patient advocacy frameworks.
But a lot of data.
It is, yeah. And looking at all this together, it completely reframes that whole dynamic. Like, we aren't just looking at doctors being dismissive. We're looking at a massive systemic translation error.
That's exactly what it is, a breakdown in communication between two entirely different languages.
Right.
You have the subjective language of human suffering and the objective language of clinical medicine, and they just don't mix naturally.
So today, we're basically giving you the dictionary. We're going to map out this really profound psychological shift.
From passive patient to fierce advocate.
Exactly. We're charting that journey, moving away from just sitting on that table, waiting for a magical cure to be handed to you, and instead taking charge of your own body.
Because the guidelines we're looking at actually validate something that you probably already know deep down.
Which is what?
That you are the ultimate expert on your own baseline, no one else.
That's so important. We're going to explore the psychology of why the medical system fails to hear you, the raw biology of how chronic pain changes your nervous system, and then the actual tools.
Right, things like the PEG score.
Yes, real structured data methods that literally force the system to stop and listen to you.
But, before we can start using those tools, we really have to look at the psychology of the person walking through the door.
The doctor.
The doctor, yeah. Because we tend to internalize a bad appointment. We walk out thinking, oh, the doctor didn't like me, or they didn't believe me.
It feels like a personal rejection.
It does. But the data from these holistic pain management sources paints a picture of a workforce that is structurally overwhelmed. I mean, to the point of failure.
Yeah, the numbers in the reports are actually kind of alarming when you think about who is treating us.
Yeah.
I mean, 66% of healthcare providers in the U.S. admit they do not always feel equipped to convey medical information clearly.
2/3.
2/3. The people we rely on for clarity literally feel unequipped to provide it.
It's a staggering admission. And it really comes down to cognitive load and time scarcity. There's this other statistic in the sources. 50% of providers stated that if they simply had 5 extra minutes per patient, they would use that time to ask about emotional well-being.
Wow, half of them.
Yeah. So the empathy is there, right? The desire to treat the whole person is there. But the modern medical machine just starves them of the time required to practice the medicine they actually want to practice.
Okay, but wait, are we letting the medical system off the hook a bit too easily here?
How so?
Because when you're the one sitting in the paper gown and your doctor cuts you off after 2 minutes, it doesn't feel like a structural time management issue.
No, of course not.
It feels deeply personal. It feels like active dismissal. Like you take your car to a mechanic because the engine sounds weird, but the mechanic only checks the tire pressure because that's what their 5-minute checklist dictates.
That's a great analogy, and it absolutely feels active, and the harm it causes to the patient is very real. I'm not minimizing that.
Right.
But understanding the doctor's psychology is how we learn to beat the system. When a human being is starved for time and under immense cognitive pressure, seeing 30 patients a day, their brain naturally relies on
Mental
heuristics.
shortcuts.
Exactly, pattern recognition. And chronic pain is messy. It does not fit neatly into a 5-minute diagnostic box. So the doctor's brain instinctively looks for a problem it actually can solve in 5 minutes.
And what does that lead to?
A phenomenon documented really heavily in the literature called diagnostic overshadowing.
Ah, yes. I found that concept really fascinating in the reading. Diagnostic overshadowing. What does that actually look like in the exam room, though?
Well, it happens when a patient's physical pain is misattributed to a mental illness or just a psychological state.
Give me an example.
Okay, imagine a patient who has been in severe, undiagnosed joint pain for months. They're exhausted, they're frustrated, and naturally they're presenting as highly distressed.
Right, because they've been hurting.
Exactly. They might even have a history of anxiety in their medical chart. So the doctor comes in, sees the tears, sees the anxiety, and their brain's pattern recognition just fires off. Distress, anxiety. I know how to treat anxiety.
Oh, wow.
Yeah. And so they prescribe an SSRI or suggest stress management.
So the doctor's brain essentially latches on to the most easily recognizable, treatable symptom, the emotional distress, and just entirely eclipses the actual physical problem.
Yes. The physical pain is completely overshadowed by the psychiatric diagnosis.
That's wild.
The system treats the stress while totally ignoring the underlying structural issue that caused it. And for the patient, this is devastating. You walk in seeking a diagnosis for a joint that feels like it's full of glass, and you walk out with a pamphlet on deep breathing.
It leaves the patient feeling like their fundamental grip on reality is being questioned,
Exactly.
which is incredibly dangerous. Because when a doctor who is supposed to be the ultimate authority on your body, when they subtly suggest your pain is just a manifestation of your anxiety, you start to internalize it.
You really do.
If you're listening to this and you've ever thought, maybe I am just weak, maybe I'm overreacting, maybe I shouldn't be this upset about my back hurting, you are actively experiencing the file-out of diagnostic overshadowing.
Perfectly said.
But the sources are so clear on this. Understanding the biological link between your mind and your body is the very first step out of that trap.
It is. Because the overlap between physical pain and mental health is not a sign of weakness. It is a profound biological reality.
Right.
There is an umbrella review cited in our sources led by Brendan Stubbs and his colleagues. Now, just for context, an umbrella review isn't just a single study. It's a review of other reviews.
It's like the highest possible level of synthesized medical evidence, right?
Exactly. It's massive. And this particular review covered over 17 million people.
Wait, 17 million? That is an undeniable sample size.
It really is.
And the prevalence of chronic pain across mental health conditions in that data is mind-blowing. Like, for people with PTSD, somewhere between 66 to 96% experience chronic pain.
Yeah, almost everyone.
In major depressive disorder, it's 53 to 65%. Almost a third of people with schizophrenia. And up to nearly 67% of people with ADHD.
It's a huge overlap.
The medical establishment used to view these as separate issues, right?
Yeah.
You go to the rheumatologist for your body and the psychiatrist for your mind. But this data proves they're the exact same ecosystem.
That's the perfect word for it, ecosystem. They refer to it in the literature as a bidirectional link. It goes both ways. The review shows that having multi-site chronic pain increases your risk of developing major depressive disorder by almost double. The odds ratio is 1.88.
But we need to explain why that happens biologically, right? So people understand this isn't just feeling sad about being hurt.
Right, it's physiological. Chronic pain is a form of severe, relentless chronic stress. When you are in pain, your body perceives a constant threat.
Like a physical attack.
Yes. It activates the fight-or-flight response, the HPA axis in your brain.
So your nervous system is just perpetually flooded with cortisol and adrenaline. It's like living with a fire alarm blaring in your house 24/7.
Precisely. And chronic exposure to cortisol literally causes systemic inflammation. It causes neuroinflammation in the brain. It physically alters the structures that regulate mood. So chronic pain biologically manufactures depression. And then the bidirectional part kicks in. When you become depressed, your brain produces less serotonin and norepinephrine.
Which, we usually just think of as the happy chemicals.
Right, but they do so much more than regulate mood. Serotonin and norepinephrine are crucial neurotransmitters in your descending pain pathways.
The descending pathway.
Yeah, they are the chemicals your brain sends down your spinal cord to inhibit or block pain signals coming up from your body.
Oh, I see.
So when depression depletes those chemicals, your brain loses its natural painkillers. It literally loses the ability to filter out the noise.
Let me make sure I'm getting this. So the depression doesn't invent the pain out of thin air.
Not at all.
The pain is 100% real and localized in your tissue. But the depression acts like an amplifier. Like, if your nervous system is a stereo, the depression just turned the volume dial all the way up to a 10 and basically ripped the knob off.
That is the exact mechanism, which is why if a doctor tells you that your pain is heavily linked to your depression, we need to completely reframe how we hear that.
Okay, let's unpack that. Because usually when patients hear that, they hear it's all in your head.
Right, but they aren't saying the pain is imaginary. What they're biologically saying is that your stereo is broken.
Interesting.
And treating the depression, lowering the anxiety, calming that fear response, that isn't a distraction from your physical pain. It is a direct biological intervention to rebuild the brain's ability to turn the volume back down.
So if someone is listening right now and feeling just completely exhausted or experiencing volatile moods or finding themselves terrified of doing anything that might trigger a pain flare-up.
Which is very common.
Yeah, that exhaustion and fear isn't a lack of willpower. It's not a personal failure. The clinical guidelines call out things like pain catastrophizing and avoidance behaviors. But those are entirely natural evolutionary responses, right?
Completely. If you touch a hot stove, your brain learns to fear the stove. You avoid it. The tragedy of chronic pain is that the hot stove is your own back or your own knee.
Oh, man. That's a brutal reality.
It is. And this realization that the pain is this tangled biopsychosocial web of biological tissue, psychological stress, and social environment, that's where the paradigm shift occurs.
Right.
Once you understand the mechanism, you can stop waiting for a passive cure. You stop waiting for a surgeon to find the one broken part to fix, and you start actively rewiring the whole system.
And the clinical handbooks use a specific word for this rewiring: neuroplasticity. The idea that our neural pathways aren't fixed like concrete, but are actually malleable throughout our entire lives.
Exactly. For a very long time, medicine operated under the assumption that if you had chronic pain for years, those pain pathways were permanently hardwired, the grooves were dug too deep.
Unfixable.
Right. But modern neuroplasticity research shows that the brain's pain maps can be modified even after decades of persistent pain. The brain can actually learn to interpret signals differently.
But there's a catch, right? The sources emphasize this pretty heavily.
Yeah, the catch is that passive treatments cannot trigger large-scale neuroplasticity on their own.
Okay, and by passive treatments, we mean things done to you. You take a pill, you get a steroid injection, you have a surgery. You're a passive recipient of the medical intervention.
Right. Now, passive treatments definitely have their place, especially in acute crises, but they have severe limitations for complex chronic pain.
Because they're just a Band-Aid.
Basically, they might temporarily lower the volume, but they don't fix the stereo's wiring. To change the wiring, you have to prioritize active interventions, things you do for yourself.
Like what?
Graded physical movement, rigorous sleep hygiene, and psychological frameworks like cognitive behavioral therapy or acceptance and commitment therapy.
Okay, let's slow down on the psychological frameworks for a second.
Yeah.
Because honestly, when a chronic pain patient hears cognitive behavioral therapy, there's often a massive eye roll.
Oh, I'm sure.
Like, you want me to talk away my ruptured disc. How does talking or changing behavior actually trigger neuroplasticity?
It's a fair reaction, but it's not about talking away the disc. It's about changing the cognitive appraisal of the threat.
What does that mean in practice?
So when you feel a twinge of pain, your amygdala, the fear center of your brain, lights up. Danger! Stop moving. CBT and ACT teach you to recognize that specific fear response, intercept it, and reevaluate it.
So you're talking back to your brain.
Exactly. You learn to say, this is a twinge, it hurts, but I am safe. I am not actively damaging tissue. By repeatedly intercepting that fear response, you literally weaken the neural connections between the sensory cortex and the amygdala.
Wait, really?
Yes, you are physically starving the fear pathway of electricity until it literally shrinks.
That is incredible. You are using your conscious thoughts to physically alter your brain's gray matter.
Exactly.
But to get to a place where you can even attempt CBT or graded movement, the guidelines point out a major psychological bridge you have to cross first: the concept of acceptance.
Yes, this is huge.
The literature almost maps this out like the classic stages of grief, doesn't it? Like when chronic pain first hits, there is immense anger, Why is this happening to me? My friends are out hiking and I am stuck in bed.
And then comes bargaining.
Right. If I just cut out all sugar, never drink wine again, and spend 3 hours a day stretching, I will be totally cured.
And bargaining is exhausting because it requires a level of perfectionism that is just impossible to maintain. And when it inevitably fails, you crash. So the final stage is acceptance.
But we need to be incredibly precise about what acceptance means in clinical pain management, right? Because it feels like the most misunderstood word in the whole field.
It absolutely is.
Acceptance does not mean giving up. It does not mean saying, I am broken, my life is ruined, I surrender to the pain, because that sounds a lot like waving the white flag.
Right.
If I tell you to accept that you have a massive hole in your roof and rain is...
I love that analogy because it really highlights the difference between passive resignation and active adaptation.
Okay, unpack that for us.
Passive resignation is sitting on the couch while the rain destroys your floorboards. Active acceptance is acknowledging the reality of the leak.
Right.
You say, okay, the roof is open. I cannot instantly stop the rain. I cannot snap my fingers and fix the shingles today.
But I can get a bucket.
I can get a bucket, exactly. I can move my expensive rug out of the way, and I can start watching tutorials on how to patch drywall.
So in the context of pain, acceptance means stopping the desperate, all-consuming search for a 100% cure, stopping the yelling at the clouds, and starting the daily work of managing the living room.
Yes.
It's directing your limited energy toward achievable functional goals, rather than trying to avoid pain at all costs.
And the clinical research backs this up definitively. Studies show that patients who exhibit greater acceptance of their pain actually report lower pain intensity, less depression, and significantly less physical disability over time.
Because they're not fighting reality.
Yeah. Exactly. Because they aren't constantly flooding their system with the stress of fighting reality. The cortisol drops, the inflammation drops, and the volume dial turns down.
So, getting the bucket, moving your rug, taking control of the active interventions. But to be the one taking control, you have to embrace a foundational truth about medical care.
And what's that?
That no one knows your body better than you do. You are the ultimate, undeniable expert on your baseline.
This is a core tenet of modern pain management guidelines, but it is deeply difficult for patients to internalize.
Why do you think that is?
Because we are socialized from birth to view doctors as omniscient. But in clinical terms, pain is entirely subjective. It is formally defined in the literature as what the patient says it is.
Right, you can't measure it like blood pressure.
Exactly. We can draw blood to check your cholesterol. We can run an EKG to measure your heart rhythm. We cannot hook a wire to your brain and get a definitive, objective pain number.
It's called the fifth vital sign in the reading. And guidelines explicitly instruct providers to accept an individual's self-reported pain as accurate.
They are instructed to, yes. But we know from the data that the reality in the exam room is often very different.
Right. And we really need to sit with this next point because the requirement for fierce self-advocacy is exponentially higher for marginalized groups.
Unfortunately, yes.
The source material is very, very clear about the structural disparities in how pain is assessed and treated. And we aren't talking about individual doctors being malicious here. We're looking at massive systemic data.
Let's talk about the data.
The literature documents profound implicit bias against Black patients in pain assessment. Black patients are consistently prescribed less pain medication and are far less likely to be referred to specialized pain clinics than white patients with the exact same presenting symptoms.
And the historical roots of that bias are deeply embedded in the medical system. For centuries, false biological myths about pain tolerance were taught as actual medical fact.
Which is horrifying.
It is. And while those explicit teachings are thankfully gone, the implicit biases, the subconscious heuristics we talked about earlier, they still linger in the split-second decisions providers make.
And the disparities span across multiple demographics.
Right.
LGBTQIA2s plus individuals face systemic hurdles, often delaying care due to previous discrimination or a lack of provider competency regarding their specific health needs.
Yes, which leads to worse outcomes.
And Native Americans report the highest prevalence of pain compared to other populations in the U.S., but the data shows they frequently only receive access to basic medications. They completely miss out on the holistic, multidisciplinary care that these guidelines define as the gold standard.
And women, too.
Oh, absolutely. Women are consistently flagged in the literature as having much higher risk factors for having their pain dismissed, minimized, or psychologized.
That diagnostic overshadowing we discussed earlier, it happens to women at alarming rates.
So this creates a massive crisis of systemic trust. If you are entering a healthcare environment, that the data shows may be structurally tilted against your credibility, the burden of proving your reality falls entirely on your shoulders.
Yes, you are walking into a room where your baseline expertise is naturally questioned.
So let's play this out. You are a patient sitting in that freezing room. You know the doctor went to medical school for a decade. You know they hold the prescription pad and the referral power. How do you respectfully assert that you are the baseline expert, especially if you fall into one of those demographics facing implicit bias?
That's tough.
How do you do it without sounding combative or getting slapped with the dreaded, difficult patient label?
You have to change the currency of the conversation.
Yeah, currency.
Yes. You shift the dynamic from a subjective plea for belief into an objective presentation of data. You do not walk in and say, you have to believe me, I'm hurting so much.
Because to them, that just sounds like,
To a rushed, stressed brain, that sounds like a vague complaint that they cannot measure. Doctors are trained as empirical scientists. They respond to structured data.
okay, so you have to speak their language.
If you want to bypass their ego, bypass their implicit biases, and assert your expertise, you absolutely have to learn to speak their language.
Which is the core of our toolkit for this deep dive.
Mm.
Translating your subjective lived experience of pain into objective data. The cognitive behavioral therapy manuals explicitly state that vague complaints are easy to ignore. You need validated tools.
Right.
Now, the sources list a few older ones, like the visual analog scale, which is basically just drawing a mark on a line, or the faces pain scale, which we've all seen, the row of cartoon faces going from smiling to sobbing.
Those tools are severely outdated for chronic conditions. I mean, they might work in an emergency room to see if your appendix is bursting, but they tell us absolutely nothing about a life lived with persistent pain.
Because a raw number is meaningless.
Right. Completely meaningless. If I say my pain is a 7 out of 10, that tells the doctor nothing about my function. My 7 might mean I am completely bedbound. Your 7 might mean you can go to work, but you're miserable the whole time.
Right. And that brings us to the absolute game changer highlighted in the clinical guidelines, the PEG score. PEG.
Yes, the PEG score.
Let's break this down completely because this is the bridge across the clinical gap.
The PEG score is brilliant because of its simplicity and its intense clinical utility. It's a 3-item scale. You rate 3 specific things on a scale from 0 to 10, and you base it strictly on your experience over the past week.
Okay, let's go through the letters.
First, the P pain average. What was your average pain level over the last 7 days?
Got it.
Second, the E, enjoyment of life. How much has your pain interfered with your enjoyment of life? 0 being no interference, 10 being complete interference.
Yeah.
Third, the G, general activity. How much has pain interfered with your general physical activity?
See, the E and the G change everything. It anchors the subjective feeling of pain to an objective reality of functional impairment.
Exactly. Let's look at how this changes the conversation in the exam room. If you walk in and say, my pain is an 8, the doctor has no actionable path forward.
But if you use the PEG,
If you walk in and say, my average pain is a 6, but because of that, my interference with general activity is a 9, so I can no longer walk to my mailbox without severe nerve pain, you have just given the doctor a specific functional deficit.
because function matters more than the raw number. The number is just a symptom. The function is your life.
Exactly.
And this ties directly into the concept of SMART goals. We usually hear about SMART goals in corporate settings or, productivity books.
Right, but the clinical guidelines insist on them for pain management.
Specific, measurable, agreed upon, realistic, time-use.
Because if your goal walking into the doctor is, I want to be completely pain-free, you are setting yourself up for failure. For complex chronic pain, 100% relief might not be medically realistic.
So what's a better goal?
If you use your PEG score, your goal becomes a SMART goal. You say, my general activity interference is a 7. I want to lower it to a 4 over the next 3 months so I can stand long enough to cook dinner for my family.
That is specific.
It's specific, it's measurable, it's realistic, and it gives the doctor a targeted metric to design a treatment plan around.
There is a crucial data point in the guidelines regarding these goals that literally blew my mind. And I think it will relieve a lot of pressure for anyone listening. The medical consensus defines a clinically meaningful improvement as a 30% improvement in pain and function.
Only 30%. That is the threshold for a successful medical intervention.
That completely redefines success. Like, we are so conditioned to think that if a medication or a physical therapy routine doesn't completely eliminate the pain, it failed.
Right.
But the science says if your PEG score drops from an 8 to a 5.5, or if your ability to walk increases by just 30%, that treatment is working. It's actively changing your life. You do not need complete eradication of pain to reclaim your baseline function.
Understanding that 30% rule is vital. It prevents the psychological despair that causes patients to abandon active treatments prematurely.
Okay, so let's put this all together into a scenario. Using the PEG score and SMART goals. I feel like it's similar to a CEO presenting a quarterly earnings report to a board of directors.
That's the perfect way to look at it, actually.
Right, because if you're a CEO and sales are terrible, you don't walk into the boardroom, slump in your chair and say, hey guys, the vibes are really bad in the office, I'm super stressed.
They would fire you on the spot.
Exactly, you have to walk in with a deck. You say, sales are down 12% in the European sector, our overhead increased by 4%, and here's our targeted strategy to regain 5% by the third quarter.
Yes.
But how do we translate that corporate executive energy into a 10-minute medical visit? What are the actual words a patient should use?
You set the agenda the moment they enter the room, before they even look at their computer. You have your data written down or on your phone, and you hand it to them. You say, Doctor, to make the most of our limited time today, I tracked my PEG score over the last month. My average pain was a 6, it interfered with my life enjoyment at an 8, and my general activity at a 7. My specific SMART goal for this quarter is to lower my activity interference enough so I can return to part-time work.
Wow.
And then you finish with, what active interventions can we implement today to target that specific functional goal?
That is powerful. You are literally doing the translation work for them.
Yeah.
You bypassed the diagnostic overshadowing completely because you didn't give them a vague emotion to pathologize.
Exactly. You gave them hard data and asked for a strategic intervention.
You positioned yourself not as a passive recipient of care, but as the project manager of your own body.
The project manager, yes.
Which leads us to the reality of executing this in the real world. Because having the vocabulary is one thing, but navigating the bureaucratic labyrinth of modern healthcare is a completely different beast.
It really is a labyrinth.
The sources transition from clinical psychology to pure boots-on-the-ground advocacy. And the resounding theme across all the patient frameworks is basically, be the squeaky wheel.
Yes. Which, let's be honest, feels exhausting when you're already sick.
Completely exhausting.
Yeah.
But the healthcare system is a massive reactive machine. It will not proactively solve your complex, nuanced problems unless you generate enough friction to force it to.
That's the sad truth.
If an insurance company denies a necessary treatment or tells you a crucial specialist is out of network, you cannot accept the first no.
Never accept the first no. A denial is just an algorithm's first pass.
So what do?
You appeal it? You ask your clinician to file a peer-to-peer review with the insurance doctor. You contact your state's health advocacy office or insurance commissioner. You have to push back.
And the advocacy guys highly recommend keeping a medical binder.
Oh, yes.
This sounds old school, but it's vital. You treat your health like a full-time job. You print out your lab results, your imaging reports, your running log of PEG scores, and your medication history.
Because you can't trust the systems to talk to each other.
Right. When you walk into a new specialist office, you don't rely on their electronic record system talking to your primary care doctor system, because half the time they don't. You pull out the binder. You own your data.
And when you're discussing options with that doctor, the framework suggests using the SHARE approach to decision-making. SHARE.
Okay, let's go through the SHARE approach. It's a structured clinical framework for shared decision-making. Right?
Yes, it breaks down into 5 steps. Step 1, seek participation. You explicitly announce to the doctor that you want to be an active participant in your care choices.
Getting the tone.
Step 2, help explore and compare treatment options. If they offer a pill, don't just blindly take the script. Ask, what are the alternatives? Are there physical therapies? What is the data on lifestyle intervention for this?
Okay, step 3.
Step 3, assess your values and preferences. This is crucial. If a medication has a side effect of extreme drowsiness and your job requires operating heavy machinery, you have to vocalize that this treatment conflicts with your functional life.
You can't just hope it won't be an issue.
Right. Step 4, reach a decision together. And then step 5, evaluate your decision. You agree to try the intervention, track your PEG score, and evaluate the 30% improvement threshold at the next appointment.
And a massive part of exploring those options, step 2, is demanding the right kind of care. The sources are definitive on this. The absolute gold standard for treating complex chronic pain is a multidisciplinary pain clinic.
Yes, multidisciplinary is key.
We are not talking about a pain management doctor whose entire practice is just doing steroid injections and refilling opioid prescriptions.
No, those are single modality clinics. A true multidisciplinary clinic is an ecosystem.
What does that look like?
It employs physicians, yes, but also clinical psychologists trained in CBT and ACT, clinical social workers, sleep medicine experts, physical therapists, and nutritionists, all sitting down together to discuss your specific case.
That sounds amazing.
If your provider isn't offering this level of integrated care, you have to actively ask for referrals to academic or hospital-based clinics that do.
And the frameworks stress that you shouldn't navigate these appointments alone. Bring a family member, a partner, or a trusted friend.
Always.
They aren't just there for moral support. They're a functional second pair of ears. When you are in pain, your cognitive load is maxed out, your working memory shrinks. Having an ally in the room to take notes, to pull out the PEG score when you get flustered, and to ask the questions you rehearsed but forgot is absolutely invaluable.
The social aspect of advocacy extends beyond the exam room, too. The literature strongly advocates for joining peer-to-peer support groups, and we need to clarify that this isn't just about emotional comfort.
There's biology behind it.
There is hard, measurable biology behind support groups.
Right, because social connection actually reduces systemic stress. Feeling seen and understood by peers who share your baseline physically alters the environment of your nervous system.
It drops your blood pressure, it reduces cortisol output.
Returning to our earlier analogy, social connection is literally another way to lower the volume dial on the broken stereo.
It is. It's an active intervention.
But I'm looking at all of this. The medical binders, the PEG scores, the SMART goals, fighting insurance algorithms, finding multidisciplinary clinics. And if I'm a patient listening to this, I'm thinking, is this fair?
Fair. No.
Is it fair that the burden of all this intense executive-level organization falls on the person who is already exhausted, depressed, and living in agonizing physical pain?
It is profoundly, fundamentally unfair.
Yeah.
The healthcare system should be a safety net designed to carry you when you are at your absolute weakest. Instead, it often demands that you be at your sharpest, most organized, and most resilient just to survive it.
It's backwards.
It is, and we have to acknowledge that grief and that unfairness. But here is the most fascinating psychological insight from the data. While it is unfair, we cannot let that unfairness paralyze us, because the very act of taking control is therapeutic in itself.
Wait, what do you mean by that?
The psychology of agency. When you track your own data, when you learn the clinical language, when you walk into a room and set the agenda, or when you fire a dismissive doctor and fight to find a better one, that physical behavioral act of taking control directly attacks the psychological feeling of helplessness.
Oh, wow.
And because pain is biopsychosocial, because the mind and the body are the same ecosystem, reducing your helplessness biologically reduces the intensity of your pain.
So the advocacy isn't just a chore you do to get the cure.
No, the advocacy is part of the cure.
The advocacy is part of the cure. By acting powerfully, you literally rewire your brain to feel less threatened. That is an incredible note to recap this journey on.
It really is.
We started by dissecting the systemic clinical gap understanding that rush doctors rely on cognitive shortcuts, which leads to diagnostic overshadowing and makes patients feel dismissed.
Right.
We unpacked the raw biopsychosocial reality of the body, validating that anxiety and depression aren't just in your head, they are biological amplifiers of your physical pain, driven by chronic stress and cortisol.
The broken stereo.
Exactly. We looked at the massive paradigm shift required to manage this, moving away from passive treatments and bargaining, and embracing true active acceptance, getting the bucket to catch the leak, and utilizing neuroplasticity to rewire the brain.
We validated the objective truth that you are the ultimate expert on your own body.
Yes, and we equipped you with the dictionary to prove it, translating your subjective suffering into objective functional data using the PEG score.
Setting SMART goals aimed at that 30% improvement mark.
And using the share approach to force the medical machine to respect your agency. It is an immense amount of work, but it is the path to reclaiming your life. Which leaves us with a final thought to mull over as we wrap up this deep dive.
Go for it.
We spent this entire time talking about how you have to adapt, how you have to learn their clinical language, bring your own charts, build a binder, and act as a fierce advocate just to navigate a flawed reactive system.
But imagine if the future of medicine actually listened to its own data and flipped the script.
Exactly.
What if we designed a healthcare infrastructure entirely around the subjective human experience? Imagine walking into a clinic where your PEG score, the strength of your social support network, and your emotional baseline aren't considered secondary psychological issues that you have to aggressively push across a desk just to be heard.
That would change everything.
Imagine if those biopsychosocial metrics were the very first vital signs taken at the door, treated with the exact same urgency as your blood pressure, before a stethoscope ever even touched your chest.
That is the medical system we deserve.
Yeah.
But until that day comes, you now have the tools and the data to demand that level of care for yourself. So the next time you find yourself sitting in that freezing room, the paper gown crinkling beneath you, waiting for the doorknob to turn, you are just a passive patient waiting to be saved anymore.
No, you're the project manager.
You are a project manager. You're preparing your data. You're setting the agenda. And you are ready to be heard.